Hi, everyone. Thanks for coming. Today I'm going to be talking about a project entitled Longitudinal Structural Covariance associated with antidepressant ECT response. And I just want to take a brief minute to motivate this work. As we've heard, major depression is the primary cause of disability worldwide. About 6% of adults are expected to suffer at least one major depressive episode per year. But unfortunately, standard first-line interventions such as cognitive behavioral therapy and SSRI interventions have a relatively low remission rate of about 25 to 50%. The STAR-D trial highlighted this pretty nicely, showing that patients who undergo SSRI interventions are expected to have about a 50% remission rate, but those who need to be cycled on to third and fourth series of SSRIs have a precipitously lower remission rate of about 25%. And part of the difficulty in treating depression stems from its overall symptomatic heterogeneity. For a DSM-based diagnosis, we know that at least 5 out of 9 symptoms are required to be present, where at least one of 2 core symptoms are also there. And this leads to a potential combination of 227 symptom constellations for the same diagnosis. And of course, there may be a variety of neurological mechanisms underlying this variety of symptom constellations that could be informative themselves of a patient's likelihood of responding to a particular treatment. This issue of heterogeneity is kind of compounded in the context of clinical trial and experimental settings where the severity of depression or its amelioration following certain treatments is assessed on the basis of some total score of a multi-item scale like the Hamilton Depression Rating Scale or the MODRS. And of course, reporting on the severity of depression on the basis of a summary score like this can easily overlook some of the idiosyncrasies of a patient's symptomatic makeup that might also be informative of their response likelihood. And so with that as motivation, this study's aims were to first identify latent pre-treatment symptom dimensions in a large cohort of ECT patients, the GEMRIC dataset that was just introduced, based on the 17-item Hamilton Depression Rating Scale, and to secondarily associate changes in these latent symptom dimensions with changes in patterns of longitudinal structural connectivity. So as was just nicely introduced, we are basing this on the GEMRIC cohort, since most individual studies of ECT imaging are rather underpowered. So I'm working with a subset of this data, actually. I needed to have data that had all of the 17 items of the Hamilton present. So this left me with 4 of the participating GEMRIC sites, which was 111 ECT patients. The average age of this cohort was 52 years with 68 females. And of course, treatment protocols did vary across these sites, but in general, they followed the procedure outlined below, where patients underwent both imaging and an HDRS assessment within 24 hours before their first ECT session. On average, they underwent 9 rounds of ECT over the course of 4 weeks, and 91 of these patients received exclusively right unilateral stimulation, whereas others may have started it off receiving bifrontal or bitemporal and a mixture of other stimulation patterns. The follow-up time point was within a week of completing the full ECT index series, and here again, imaging and HDRS measures were collected. So in order to recover these latent symptom dimensions that I was talking about, we conducted an exploratory factor analysis of these 17 items at the pre-treatment time point. We used here an oblique Oberlin rotation for our EFA, and this recovered a 3-factor solution that best fit the data. This largely divided the 17 items into dimensions of somatic disturbances, highlighted in red on the right figure, core mood and anhedonia, and in blue, an insomnia dimension. And so from here out, the patient's individual weightings onto these 3 latent dimensions are the outcomes for the models that I'll be discussing. And again, part of our goal was to relate patterns of longitudinal structural covariance over the course of ECT to changes along these latent symptom dimensions that I showed in the last slide. So I'm just going to take a minute to outline how we went about this. We segmented all patients pre and post ECT MRIs with FreeSurfer, yielding estimates of cortical thickness and subcortical volume for 48 ROIs. We calculated the percent change for each of these ROIs over ECT index, pre to post. And for each patient, we calculated the pairwise ratio of percent change between all ROIs, yielding a matrix for each patient of 48 by 48 in dimension, where an element in this matrix is the ratio of the percent change in ROI A to ROI B. We then thresholded this ratio matrix for each subject using 8 adjacent but non-overlapping windows over the distribution of these ratios between the ranges of +1 to 10. And in this framework, the windows that are closer to 1, the lower valued windows, capture patterns of similar structural changes between ROIs over ECT, whereas the higher valued windows that are closer to 10 capture patterns of dissimilar or maybe even divergent trajectories of the regions over index. And so thresholding these ratio matrices this way leaves us with a set of 8 binary adjacency matrices per subject, 1 per window. These adjacency matrices, of course, can be represented as graphs in the usual fashion, where each node in the graph is an ROI, and an edge between the nodes indicates that the ratio of change between the regions falls within a ratio window that corresponds to the underlying adjacency matrix that gave rise to the graph. So I can make this more concrete here. So for example, if a patient's right hippocampus node in a window from ratio range 2 to 3 has 5 edges, as is shown here, that would suggest that this patient's right hippocampus changed 2 to 3 times more than these 5 other regions that it's connected to. But just a caveat to mention is that directionality isn't directly encoded in this framework. That has to be inferred with post hoc tests. But nevertheless, we can take the set of all of these node degrees across all subjects and across all windows and use them as predictors in a random forest regression model, along with patient age, sex, site, baseline severity, to predict changes along each of these latent symptom dimensions. We also use 10 repeated 10-fold cross-validation to train and test each of these models. And there was a process of nested feature selection because the dimensionality of this problem is pretty high. And that was based on recursive feature elimination. And we also did an internal grid search to optimize the parameters of the random forest. And so we can look at how each of these latent symptom dimensions changes over ECT index. So these are box plots of the pre to post treatment severities of these symptom dimensions, broken up obviously by color here. And you can see that all are significantly improved. That is reduced over ECT. But interestingly, there was more improvement along the insomnia dimension than the somatic dimension in this case. So this may suggest a differential effect of ECT on these latent symptom dimensions, but a lot more needs to be done to sort of tease that out. Moving on to the results of the random forest regression, this is the result of the cross-validation process. So in these scatter plots, I'm showing the predicted versus actual change along these 3 latent symptom dimensions, and for comparison, the predicted versus actual change along the total HDR-17 score as a percentage. And so a number of interesting things start showing up here. First, you can see that the correlation between predicted and actual is significantly above 0 for each of these, but it's significantly higher for these latent symptom dimensions. So that might start to suggest that using these data-driven approaches to refine the outcomes, the target outcomes for these sort of predictive models where we're trying to predict antidepressant response or just identify biomarkers of response, this might be a useful approach above using a total score. Another interesting note here is that the predicted versus actual change correlation was significantly lower for the somatic disturbances dimension, and you can see that there's kind of a curvilinear association here between predicted and actual, where patients that change the most, highlighted in the bottom left of that plot, are predicted fairly well, but patients that either don't change or perhaps even for whatever reason get worse with ECT aren't predicted well at all. So next we can start to ask what are the underlying patterns of longitudinal structural connectivity that associate with each of these latent symptom dimensions. And so to probe this, we went back to the random forest and evaluated what the most important features are in the random forest to the prediction of change along each of these individual symptom dimensions. And here I'm plotting the 5 most important networks in the prediction of change in the somatic factor. And so we can start looking at each of these broken up by which thresholding window they came from. And so first here you can see it highlighted in red, a network of covariance. This is emerging from a ratio window very close and close to 1 that's centered on the left lateral occipital cortex and has edges to the cuneus and the superior parietal cortex and the fusiform, as well as the contralateral lateral occipital. This set of networks came from a window of slight divergence between ratios 2 to 3 and captured divergence between, in yellow, the, again, left lateral occipital cortex with projections to the ipsilateral limbic regions, which includes the ACC. Also, the ipsilateral temporal pole was captured in this network. And in green, you can see another network of divergence centered on the right hippocampus with edges to a variety of other sensory integration regions and temporal regions. So this is kind of interesting because some of the ROIs captured by these networks, as has been shown, are very relevant to both depression and the treatment course of ECT. For instance, the hippocampus is captured here, which is commonly atrophied in patients with depression and changed with ECT. The ACC is captured here, and a number of sensory integration regions are involved, which makes sense within the context of this somatic factor. This set of networks captured more severe divergence, this time between the anterior cingulate in the left hemisphere and the temporal region in the left hemisphere to a variety of other sensory integration regions. Moving on to the anhedonia and core mood dimension, here is an overlay of the 3 networks most associated with it. First, we observed a network of moderate covariance between the right lateral OFC and a number of ipsilateral frontoparietal regions, as well as a handful of temporal regions. The contralateral hippocampus and contralateral OFC were also captured by this network. And again, there's some interesting regions here as the hippocampus is commonly involved in depression, as I said, and the lateral OFC is commonly involved in emotional regulation, which is perhaps, again, fitting within the context of this mood dimension. Here was a network of more divergence between the right hemisphere accumbens and a variety of ipsilateral limbic regions, including the amygdala, hippocampus, and the fusiform region, as well as the contralateral precentral cortex. Perhaps this captures aspects of negativity bias and reward processing in patients with depression. And here was another network of stronger divergence between the entorhinal and ipsilateral occipital regions and a variety of other contralateral occipital regions. And then lastly, the insomnia dimension was well characterized by a network of tight covariance between the right inferior temporal lobe and a variety of ipsilateral medial temporal structures, again, the contralateral hippocampus and the pars opercularis. Another network captured moderate covariance between the left putamen and a variety of frontotemporal regions in the contralateral hemisphere. Again, very fitting here, the medial OFC is captured, pars triangularis, and a variety of other regions. And lastly, a network of strong divergence centered on the right hemisphere pericalcarin, which diverged in this case from regions like the right rostral ACC and a number of other important regions like the amygdala and hippocampus in the ipsilateral hemisphere. So just to briefly summarize, we conducted an exploratory factor analysis of the 17 items of the Hamilton in the large GEMRIC cohort prior to their treatment. And this identified 3 latent symptom dimensions that captured patterns of somatic disturbances, insomnia, and core mood and anhedonia. Changes along these symptom dimensions were better predicted, interestingly, than changes along the HDRS total score, So this might start to suggest, like I mentioned before, that these sorts of homogenized outcomes could serve as better targets for biomarker identification and predictions of clinical outcome in related studies. These symptom dimensions, as they changed over ECT, also exhibited interesting, unique, but also overlapping associations with these patterns of structural covariance that I just highlighted. So this has some treatment implications in that, perhaps as many suspect, targeted neuromodulation of specific structural or functional networks may affect specific symptom dimension profiles differentially. And this may lay the groundwork for more individually tailored treatment strategies, which are, of course, desperately needed in psychiatry today. So with that, I want to thank all of you for coming out this morning and for your attention. And a special thanks to my mentor, Catherine Nahr at UCLA, and all of you who are involved in GEMRIC, and Leif Oltedal, who coordinates GEMRIC. Thank you.